Hi, my name is Shih. The project that I am going to present today entitles Balanced Recovery Responses in Individuals with Unilateral Below-the-Knee Amputation. Reported that in 2019, there were 176 million people lived with lower limb amputation worldwide. Among all types of amputation, below the knee is the most prevalent type of major amputation, which is defined as losing at least one of their major lower extremity joints, such as their ankle, knee, or hip. In this specific population, 50 to 80% of them reported fell at least once in a year, which resulted in physical injuries and influenced their psychosocial well-being, and tripping falls is one of the leading causes. The definition of a trip is an abrupt disruption of the normal leg-torso coordination. As you can see in this short video, the trunk forward momentum continues while a foot is obstructed, and this foot obstruction is usually unilateral, which means for persons with unilateral lower limb amputation, it happens either to their prosthetic side or to the intact side. After amputation, this population exhibited a symmetric movement pattern when performing different activities, from standing to sit-to-stand and to even walking. They tend to bear more weight by using their intact limb and unload their prosthetic limb during level walking so that there could be less energy consumption. However, it may be less accommodating when they confront perturbations. Individuals with unilateral below-the-knee amputation use their limbs differently. It is possible that when the trips occur to their intact limb versus their prosthetic limb, their responses could be different. And investigating these site-to-site differences is the purpose of this study. And the findings of this study may bring us the biomechanical knowledge that could be potentially used to design a tripping fall prevention intervention. After acquiring consent, we provided a safety harness to our participants. The harness was attached to the low cell, which allowed us to monitor how much it supported the participants. And we placed a trunk and lower extremity marker set to the participants and randomly delivered 4 different perturbations. Small perturbations to the prosthetic side and intact side, large perturbations to the prosthetic side and intact side, which is abbreviated as SP, SI, and LP, LI. The first dependent variable is the fall incidence. We calculated 3 durations. In a typical recovery after the perturbation applied to the trip limb, in this figure, the orange limb, participants made their first recovery step using their contralateral limb and a second recovery step using the ipsilateral limb. And we call the 2 steps as the full course of recovery. The 3 durations we calculated were the duration of the first recovery step from perturbation onset to the contralateral limb contact the ground, and the duration of the second recovery step from contralateral limb contact the ground to the ipsilateral limb contact the ground. And lastly, the duration of the full course of recovery. We recruited 12 participants who had a wide range of age and walking speed. Overall, the participants fell more when the perturbations delivered to their intact limb than to their prosthetic limb. When it comes to the duration of the first step of recovery, we found that when the perturbations applied to their intact limb, this duration was significantly longer. Remember that this step was done by the contralateral limb, so in this case, the step was made by the prosthetic side, and it took longer time. We found that when the perturbations applied to the intact limb, this duration was significantly shorter. And please allow me to remind you again that this step was done by the ipsilateral limb. So in this case, the step was done by the intact side, and it took shorter time. When it comes to the full course of recovery, the durations did not significantly differ side to side. According to literature, the longer duration of recovery step made by the prosthetic limb could be due to the dampened detection of sensory information and the delayed responses of the prosthetic limb, because the sensory and motor organs below the amputation level are all gone. Additionally, it has been shown that the anterior-posterior movement rely heavily on the ankle, and in this case, the trip recovery, the movement are mainly anterior-posterior. So our participants, they all lose their ankle due to amputation, so it is possible that the recovery movement in this sagittal plane was compromised. Hence, in conclusion, we would suggest that the recovery step making by the prosthetic limb is the key to a successful trip recovery. And thank you for listening.